Welcome to the Radong Smart Review Head and Neck Cancer Series.
Today, we are diving into what is probably one of the most critical decision points in all of head and neck oncology.
Absolutely. We're talking about the right adjuvant management for oral cavity squamous cell carcinoma after a patient's had surgery.
And this isn't just, abstract theory. This is literally about looking at a pathology report and understanding that every single line item has these huge, life-altering clinical implications.
That's so true. This whole discussion is really tailored for you, the resident, to get past just memorizing things
Right.
and to really embrace the nuanced decision making that goes into postoperative management.
Exactly. We're going to define precisely when a patient needs just postoperative radiation therapy, or PORT as we call it, versus when you have to escalate to that much more intense concurrent chemoradiation.
And our mission today is to really solidify your understanding of the big two. These are the high-risk indications that trigger adding chemotherapy.
To do that, we're going to critically analyze the foundational evidence. We're talking R-TOG 9501, the Cooper trial, and EORTC 22931, which is the Bernio trial.
And we're not just going to recite the data. We're going to dissect the subgroup analyses that actually led to our current standard of care.
So by the end of this, you should be able to look at any oral cavity path report, assess all the risk features, and then answer in just one sentence: PORT versus chemo-RT, and most importantly, why.
And be able to justify it with the specific trial data.
Exactly. So let's anchor this whole discussion with a core clinical scenario. We'll keep coming back to this one.
Okay, let's hear it.
Our patient is a 58-year-old man. He has a significant 30-pack year smoking history and moderate alcohol use. 3 weeks ago, he had a composite resection for a PT3 and 2B oral tongue squamous cell carcinoma.
So that included a partial glossectomy and an ipsilateral selective neck dissection.
Right. And he's currently healing, but the clock is ticking on his adjuvant management decision.
Okay, a perfect case. Let's unpack this, starting with the fundamentals: anatomy, epidemiology, and risk factors.
So with this patient, we have a really classic presentation of oral cavity cancer. What makes him such a textbook example in terms of, the etiology?
Well, the primary risk factors are just perfectly aligned, aren't they? A long history of chronic tobacco exposure, 30-pack years, combined with chronic alcohol use.
And they're synergistic carcinogens.
Exactly. And for the resident, it is so important to remember that this combination drives the whole concept of field cancerization.
Meaning the entire mucosal lining of the upper aerodigestive tract is at risk.
That's it. That risk doesn't just go away because we treated the one tumor. It's still there.
That's a crucial concept, and it ties directly into how we manage these patients. I mean, unlike oropharyngeal cancer, which has seen this massive shift toward HPV-driven definitive chemoradiation.
Right.
Oral cavity cancer is still fundamentally a surgically managed disease. The role of radiation here is almost always adjuvant.
Just cleaning up microscopic disease left behind after the resection.
Exactly. And since our patient have an oral tongue primary, we need a really focused anatomical review, especially when it comes to nodal drainage. Delineating the CTVs is, well, it's everything.
Okay, so the oral cavity includes the oral tongue, floor of mouth, buccal mucosa, hard palate, retromolar trigonone. For these spots, the lymphatic drainage is super predictable.
So we're mainly concerned with the ipsilateral nodal levels, right?
Right, we're talking level 1B, level 2, and level 3.
But we need to be precise about level 1A and, the role of level 4.
Good point. So level 1A, the submental nodes, that's typically only at risk if the primary tumor involves the floor of the mouth or maybe the anterior oral tongue tip.
Which wasn't the case here. Our patient was more posterior oral tongue.
Right. So the risk to 1A is lower, but it might still get covered in the level 1B volume. But levels 2 and 3, those are the workhorse nodal stations for pretty much all oral cavity primaries.
How about the lower neck then? Level 4.
Level 4 is often spared in, say, an early stage N0 oral cavity cancer. But since our patient is N2B locally advanced, including level 4, even electively becomes much more likely.
Especially if there was extensive level 3 disease.
Exactly. That's a key distinction between early and advanced disease. But we also have to talk about anatomical exclusions. What's the most common trap with nodal coverage in these cases?
Oh, it's the retropharyngeal nodes. This is such a classic oral board question. It really separates the residents who know the anatomy from those who are just, painting with a wide brush.
So to be clear, retropharyngeal nodes are generally not considered at risk for primary oral cavity tumors.
Full stop. They're for primaries in the oropharynx, the nasopharynx, and maybe sometimes the hypopharynx.
And including them unnecessarily just adds toxicity. You're hitting the pharyngeal constrictors for no real benefit in an oral tongue primary.
Knowing what parts of the map to ignore is just as important as knowing what to cover. Okay, so we've framed the risk and the anatomy. Let's move on to how the patient was actually diagnosed and staged before surgery.
Right, the Janie always starts with the initial workup. That's a physical exam, mapping the gross tumor, and often a penendoscopy under anesthesia to check for synchronous primaries.
Yes. And of course, the biopsy confirms squamous cell carcinoma.
Then comes the imaging. This is where we get our first real look at how extensive the disease is. So what are the complementary roles of CT, MRI, and a PLET CT in that pre-op phase?
Okay, so CT scans with contrast are great for looking at bony structures. Specifically, you want to assess for mandibular involvement. That's a huge T-stage and surgical consideration.
And it gives a pretty decent quick look at the neck nodes.
It does. But when you're dealing with a soft tissue primary like the oral tongue, MRI is just superior.
No question. MRI gives you that contrast resolution you need to really accurately assess soft tissue invasion, and that's critical for two big things.
Okay, what are they?
First, determining the depth of invasion, or DOI, which, as we'll see, drives the T-stage in our case.
And second,
MRI is the best way to assess for involvement of named nerves. It's sort of the precursor to seeing perineural invasion PNI on the final path report.
and the PTCT.
Its primary role is ruling out occult distant metastatic disease, the M0 status. You do this in patients with locally advanced nodal disease, so N2 or N3.
So it basically helps ensure you're not putting a patient with incurable distant mets through a massive surgery and chemoradiation.
Exactly. For a truly early stage N0 patient, the utility of a PCT is much lower. It's often not even required. But our guy was N2B, so a pre-op PTCT was standard to confirm he was M0.
Okay, so let's apply the AJCC staging system to our case using the final post-op pathology report. That's a definitive document.
And the path established him as PT3, N2B, M0, which is stage 4A disease. Let's break that down. Why PT3?
Well, the key stage in oral cavity cancer has some major shifts. It's moved away from just surface size to focusing heavily on depth of invasion.
Okay.
Our patient had a 3.2 centimeter surface size. Now, that alone would usually be T2, but the critical finding was the 12 millimeters of depth of invasion.
And once DOI goes over 10 millimeters, it's automatically T3.
Exactly. Regardless of the surface dimensions, that 12 millimeters of DOI is why he's a T3.
Okay, makes sense. And how did that lead to N2B?
N2B is defined by having multiple positive ipsilateral nodes, but none of them are bigger than 6 centimeters. Our patient had 3 out of 24 nodes positive.
And the largest was 2.8 centimeters.
Right, so multiple positive ipsilateral nodes. He falls squarely into N2B. M0 means no distant disease, confirming that stage 4A classification. This is a locally advanced patient, and the post-op management is very high stakes.
So we're dealing with standard squamous cell carcinoma. And as you said earlier, for oral cavity cancer, we can kind of leave the molecular markers aside.
Yeah, HPV status, P16 staining. It's not relevant for determining the need for adjuvant therapy here. The decision is purely based on those traditional pathologic high-risk features.
And this is where we define the pathologic risk ladder. For the resident listening, this is probably the most crucial skill, translating the pathologist's report into a treatment recommendation.
Absolutely. The decision to observe, to irradiate, or to intensify with chemotherapy rests entirely on that report.
So here's where it gets really interesting, because we have to identify the features that justify this massive leap in toxicity, the features that push a patient from just needing PORT alone to needing concurrent chemoradiation.
Those are the high-risk features, universally known as the big two. If either one of these is present on the path report, it triggers concurrent chemoradiation. Full stop.
What are they? And how precisely do we define them?
Number 1, a positive surgical margin. And we have to be so precise here. This is defined as tumor on ink. It means the surgeon's resection line was microscopically involved with cancer.
Okay, tumor on ink. And number 2?
Number 2, extranodal extension, or ENE. This means the tumor has extended through the lymph node capsule into the surrounding soft tissue. It's basically breached its biological containment system.
And our case patient had ENE up to 3 millimeters in 2 nodes.
Yes. The moment that finding was confirmed, that patient was locked into the high-risk chemoradiation category.
That is the key clinical differentiator. But since our patient has a whole bunch of other concerning findings, Let's define the intermediate risk features.
Right, because these are still highly significant. They absolutely trigger post-operative radiation.
And this is the key. They do not independently require adding concurrent chemotherapy because that survival benefit just isn't established for them alone.
Okay, so the intermediate features include, 1, a close margin, typically defined as less than 5 millimeters, but critically not tumor on ink. Our patient had a 2 millimeter margin. That's a significant intermediate feature.
It needs dose escalation, but not chemo on its own.
Right. 2, multiple positive lymph nodes without ENE. So, for example, 5 or 6 positive nodes, but they're all still contained within the capsule.
What else?
3, paraneural invasion, or PNI cancer cells tracking along a nerve. Our case had this, involving named nerves. 4 is lymphovascular invasion, or LVI cancer cells in small blood or lymphatic vessels, also present.
And then there's the T stage and node size.
Exactly. Pathologic T3 or T4 primary tumor, or PT3 qualifies. And a large node, greater than 3 centimeters. Ours was 2.8, so just under. But still, it adds to the overall risk.
So our anchor case is just a perfect illustration of this. He is drowning in intermediate features, close margin, PNI, LVI, PT3 status.
The single presence of that 3 millimeter ENE is the tiebreaker. It supersedes everything else, and it mandates chemoradiation.
So if he only had those intermediate features, the recommendation would have been PORT alone.
That is the distinction we have to hammer home.
Yeah.
The presence of PNI or LVI tells us the tumor is aggressive,
Yeah.
that it has pathways to spread. But the pooled data we're about to discuss failed to show that adding systemic chemotherapy for those features alone actually translated into an overall survival benefit.
Okay, so let's use a simple mnemonic to make sure these high-risk indicators really stick. We know that chemotherapy comes with a really steep increase in toxicity.
Right. So we use PE as the price for chemo,
P for positive margin.
and E for ENE, extranodal extension.
A simple clinical way to remember which patients have to pay that price. Okay, now that we have the framework, let's justify it by diving into the trials that defined this standard of care 20 years ago.
The current standard of care for adjuvant head and neck SCC, the rulebook for the big two, it was defined by 2 huge cooperative group trials. They were published back-to-back in the New England Journal of Medicine in 2004. Every resident has to know these trials inside and out.
Okay, we'll start with the American trial, R-TOG 9501, better known as the Cooper trial.
This was a large randomized controlled trial, 459 patients. They'd all had resection for locally advanced head and neck cancer from various subsites, oral cavity, oropharynx, hypopharynx, larynx.
And the key design element here is the inclusion criteria. Patients had to have at least one high-risk feature.
But crucially, their definition of high risk for entry included a positive margin, ENE, or, and this is the important part, 2 or more positive lymph nodes. We'll see why that third category complicates things later.
Right, so the randomization was pretty simple. Arm 1 got PORT alone, 60 gray, with an optional boost to 66. Arm 2 got the same PORT, but with concurrent cisplatin.
The standard dose, 100 milligrams per meter squared every 3 weeks for 3 cycles.
So what was the primary takeaway from Cooper?
The big headline finding was a significant improvement in locoregional control, or LRC.
Okay.
The 2-year LRC rate was 72% with radiation alone versus 82% with chemoradiation. That 10% absolute improvement was highly statistically significant, p-value of 0.01.
So here's where the nuance in the debate really start. The primary overall survival, or OS, benefit. It wasn't statistically significant in the overall population.
Right. It was 57% versus 63% with a p-value of 0.19.
So we get asked this a lot. If OS wasn't significant, why did we immediately adopt chemo-RT based on this one study?
That's a great resident question. The immediate adoption was justified because LRC is a highly validated surrogate endpoint in this disease, and the size of that benefit was substantial.
And also, the distant metastasis rate was nearly identical in both arms. It was hovering around 20%.
And that fact drives the single most important clinical pearl from this trial. Chemotherapy in this adjuvant setting is for local regional intensification. It's for killing microscopic disease left in the surgical bed and the nodes.
It is not effective for systemic coverage. The rate of cancer spreading elsewhere was totally unaffected by adding cisplatin. We're fighting regional failure, not distant failure.
So what was the cost of gaining that 10% LRC advantage?
The cost was massive. Acute grade 3 to 4 toxicity, we're talking severe life-threatening toxicity. It jumped from 34% with radiation alone to 77% with chemo.
More than double.
More than a doubling of severe side effects. And this steep cost is precisely why we can't just give chemo to everyone. We need extremely tight indications.
Okay, now let's turn to the European counterpart, published at the exact same time, EORTC 22931, the Bernier trial.
This trial had 334 patients. And crucially, the patient selection was a bit broader than Cooper's.
How so?
Well, they included positive margins and ENE, but they also allowed patients with intermediate risk features. Things like PNI, LVI, T3 to T4 status, and N2 to N3 disease, even without those highest risk features. This broader inclusion is vital.
The arms were essentially the same, though. PRT alone versus PRT with high-dose cisplatin.
Right. But the key difference in the outcome here is that the Bernier trial did show a definitive overall survival benefit.
This is the definitive piece of evidence. The 5-year progression-free survival went from 36% to 47%, which was significant. But the money shot was the 5-year overall survival.
40% with radiation alone versus 53% with chemoradiation.
That 13% absolute difference was highly significant, p equals 0.02.
This is the trial we cite that gives us that clear overall survival benefit, justifying concurrent chemoradiation for these high-risk patients.
And they also cut local regional relapse from 31% down to 18%.
So, to sum up, Cooper gave us the strong LRC signal and the reality check on toxicity. Bernier gave us the definitive OS signal. But because of how they each defined high risk, there was still some ambiguity about which specific features truly warranted the chemotherapy.
And that brings us to the pooled analysis.
Yeah.
This was published by Bernier in 2005, and it is the cornerstone of modern adjuvant head and neck oncology.
They combined almost 800 patients from both trials and did subgroup analysis to really define who derived that survival benefit from chemointensification.
Okay, let's unpack this. What did the pooled data establish about our big two?
The analysis clarified, with a lot of statistical power, that the overall survival benefit from chemo was concentrated only in patients who had ENE and/or a positive margin.
And this is the critical distinction residents have to internalize. For intermediate risk features alone, so multiple positive nodes without ENE or PNI and LVI alone, the benefit from adding chemo was statistically not established.
Right. The p-values in those subgroups were like 0.33 and 0.78.
In plain English, the toxicity was not justified because adding chemo didn't significantly move the survival needle for those patients.
This is why the quality of the risk feature, like ENE, is more important than the quantity, like the node count, which brings up a common oral board trap.
A node count question.
Exactly. Does having 5, 6, even 10 positive nodes, as long as the pathologist says no ENE, trigger chemo?
A secondary analysis of this data confirms that node count alone does not trigger chemotherapy. If a patient has 5 positive nodes without ENE, PORT alone is still the standard.
We are treating the breach of the capsule, the ENE, which represents a far more aggressive biology, rather than just the number of involved nodes.
Okay, before we cement this algorithm, we have to discuss the recent trial that, for a minute there, threw this whole consensus into question. The OCAT trial from 2023.
OCAT is significant because it was a large phase 3 trial that focused only on oral cavity cancer.
Which is a key subsite that was kind of mixed in with others in those older cooperative group trials.
Right. But the result was totally unexpected. It showed no difference in local regional control or overall survival when comparing RT alone, RT plus weekly cisplatin, or accelerated RT.
Wait, so if OCAT, which was purely oral cavity, showed no benefit for chemo, why are we still sticking to the Big Two rule based on 20-year-old data? This is a critical point.
You have to look at the differences. OCAT was a single institution trial, so the standardization might not be as rigorous as a huge cooperative group study.
And more importantly,
The rate of positive margins, one of our absolute big two triggers, was extremely low in OCAT. It was only 0.4%.
and the benefit of chemo is concentrated in those patients with the most severe risk factors.
So OCAD essentially studied a population that was lower risk than the population that drove the OS benefit in the EORTC trial. The benefit might have been impossible to detect because the highest risk patients just weren't there.
That makes sense. And there's also the detail of the chemo itself. Cooper and Bernier used high-dose, Tri-weekly cisplatin.
100 milligrams per meter squared q 3 weeks.
OCAT used weekly cisplatin at a much lower cumulative dose.
And while weekly cisplatin is often used for definitive treatment, the standard of care for the adjuvant setting, especially for the highest risk group, is still that high-dose Q3 a week regimen.
So OCAT's findings, while provocative, they don't currently override the robust cooperative group data for patients with the big two. The standard remains chemo-RT for positive margin and E&Es.
Okay, now let's synthesize all this evidence into a really straightforward if-then risk ladder. This is the algorithm for board exams and, for rapid clinical decision-making.
Let's run through it step by step, linking it back to our PE mnemonic.
Okay. If the pathology report states positive surgical margin, the P, tumor on ink, then the recommendation is post-operative chemoradiation.
If the pathology report states extranodal extension, the E, regardless of whether it's 1 millimeter or 3, then the recommendation is post-operative chemoradiation.
If the features are solely intermediate risk, so a close margin like in our patient, multiple positive nodes without E&E, PNI, LVI, or PT3T4, then the recommendation is post-operative radiation alone.
And finally, the low-risk patients, PT1 or PT2, widely clear margins, PN0, no PNI or LVI. For them, observation may be appropriate.
That clarity is just essential. But all of this risk stratification means absolutely nothing if we fail on the logistics. We have to talk about the one non-negotiable factor that influences outcome, maybe as much as E&E itself.
And that is the critical importance of timing, or package time.
This is where resident responsibility really meets oncology reality. The foundational MD Anderson data, first published by Peters way back in '93, showed compelling evidence that prolonging the total package time from surgery to finishing radiation worsens LRC and OS.
So what's the clock we're racing against?
The threshold we always cite is that RT must begin within approximately 6 weeks of surgery.
This allows for an optimal total treatment package time surgery to RT completion about 11 to 13 weeks.
And every week of delay beyond that 6-week start date allows the microscopic disease the cancer cells were trying to kill to proliferate aggressively. This is driven by accelerated clonogen repopulation.
That biological mechanism is so key. Once you remove the primary tumor, the remaining microscopic cells lose those inhibitory factors from the large tumor mass, and they just start dividing faster.
So if we delay RT, the tumor burden rebounds, and the dose of radiation we plan becomes insufficient to control that higher number of cells.
So for our anchor case, the patient is 3 weeks post-op. We have to use that remaining 3-week window to get him through dental, planning CT sim, QA, and start treatment immediately.
Delaying until week 8 or 9 because of some bureaucratic holdup or poor wound care is effectively worsening the patient's prognosis.
This is a crucial management detail. If a board examiner gives you a delayed start scenario, your answer has to involve urgency, documenting the suboptimal delay and starting treatment right away. You do not wait.
Let's integrate all of this by delivering the 60-second board script, just as we would in an oral board exam, applying everything to our anchor case.
Okay, examiner. How would you present and manage this patient, a 58-year-old man, 3 weeks post-op, PT3, N2B, oral tongue SEC, with E&E?
Examinee. This is a 58-year-old man with PT3, N2B oral tongue squamous cell carcinoma following composite resection. He has multiple adverse pathologic features. The most important finding is the presence of extranodal extension in 2 nodes. This is one of the big 2 indications, or PE features, and requires post-operative chemoradiation per the survival benefit demonstrated in EORTC 22931 and the pooled analysis. Additional intermediate features include a close margin of 2 millimeters, perineural invasion involving named nerves, lymphovascular invasion, and PT3 status. While these features reinforce dose and volume intensity, they are not independent triggers for concurrent chemotherapy. He should receive 60 to 66 gray to the high-risk volumes with concurrent cisplat in at 100 milligrams per meter squared every 3 weeks for 3 cycles. Treatment must begin within the next 2 to 3 weeks to stay within the 6-week threshold established by MD Anderson data, optimizing the total treatment package time. R-TOG 9501 showed that adding chemotherapy improves 2-year local regional control from 72% to 82% for high-risk patients like this.
That is the comprehensive answer. It hits the risk, the rationale, the dose, the chemo, and the timing, all in a very focused response.
Okay, so we've confirmed the need for chemoradiation. Now let's detail the implementation, the actual radiation planning process. This means precise, dose, and target volume prescriptions.
Right. This is crucial for the resident audience. We use differential dosing based on the risk level within the volume, often delivered with IMRT or VMAT. Let's specify the dose and fractionation for our case.
Okay, we're using 2 grays per fraction. For high-risk volumes, so that's the surgical bed with the positive margin area if there was one, and the nodal levels with E&D, the prescription is 60 to 66 gray.
And we lean towards 66 gray if there was gross tumor on ink at the margin, right?
Exactly, or extensive E&E. For our patient with E&E, 60 to 66 gray is the right range.
And for intermediate risk volumes. So the rest of the surgical bed, the involved nodes that didn't have unique, and areas with PMAs.
The dose there typically falls between 54 to 60 gray. We might choose 60 grays for the area with that close 2 millimeter margin to really reinforce the dose intensity where the risk is high.
And in the elective volumes, covering uninvolved nodal levels.
Those get 44 to 50 gray with conventional fractionation. Or, increasingly, we use an SIB technique, a simultaneous integrated boost.
Where you deliver all the doses concurrently.
Exactly, across 30 to 33 fractions. It streamlines the total treatment time and might help mitigate that clonidine repopulation.
Okay, let's talk target volumes and CTV delineation. This is often the hardest part of post-op planning, especially with these complex reconstructions.
For the high-risk CTV, you have to cover the entire original tumor bed plus margins and any nodal levels that had E&E. So for our patient, that means level 2 and level 3 on the ipsilateral side are now high risk, needing that 60 to 66 gray dose.
What are the essential elective CTVs for an oral tongue primary?
Given the drainage, we're targeting ipsilateral levels 1B, 2, and 3. Since it was oral tongue, you have to check if the floor of mouth was involved. If so, you include level 1A.
And you have to be judicious about levels 4 and 5.
Very. Advanced N2B disease often warrants level 4 coverage, but level 5 is usually only for posterior primaries. And as we stressed before, we are specifically excluding the retropharyngeal nodes.
Now, this whole planning process is made so much harder by post-op anatomical distortion. What is the critical planning pitfall that residents have to avoid?
It's simple, but it's catastrophic. Failing to fuse the preoperative MRI to the planning CTU.
Because after a composite resection and a free flap, which our patient likely had, the anatomy is just unrecognizable.
Totally. The original tumor boundaries, the GTV, it's all gone. You cannot accurately delineate the high-risk surgical bed, especially for PNI or close margin areas, without that pre-op MRI. That fusion step is absolutely non-negotiable.
And how does the free flap itself influence planning?
Immobilization is key, so a shoulder mask is required. As for the flap, its vascular supply is sensitive to high-dose radiation. We have to work closely with the surgeon to understand where the vascular pedicle is to ensure we don't create an unnecessary risk of flap necrosis. But usually, standard PORT doses are safe.
Okay, let's wrap up planning with key organ at risk constraints, OARS. What are the major ones we're tracking here?
We always have to protect the spinal cord, so max dose less than 45 gray. The mandible is a huge concern because of osteoradionecrosis, or ORN.
So we aim to minimize the volume getting 60 to 65 gray and critically avoid any hotspots over 70 gray.
Every gray above 65 just shoots up the risk of ORN, which is devastating.
And of course, the salivary glands to manage xerostomia.
Yes. We track the contralateral parotid, aiming for a mean dose less than 26 grays. Hitting this constraint is the difference between a patient having some functional saliva left and being totally dependent on artificial saliva for the rest of their life.
It's a huge quality of life issue.
Huge. And we also track the larynx and pharyngeal constrictors to try and preserve swallowing.
Okay, so our patient is high risk. He needs chemoradiation, which, as Cooper showed, drastically increases severe toxicity. We have to counsel him on this. Let's deliver the patient counseling script, focusing on being transparent about the risks and benefits.
Mr. Patient, I reviewed your pathology with our team. The surgery was successful, but the pathology shows some features that tell us microscopic cancer cells may still be present. Specifically, in 2 of the lymph nodes, the cancer had broken through the capsule into the surrounding tissue. We call this extranodal extension. This is the main finding that tells us you need radiation combined with chemotherapy.
Based on large clinical trials, we know that adding chemotherapy to radiation improves local control from about 72% to 82% at 2 years. We're essentially giving ourselves a stronger guarantee that we kill all the cells left behind. The chemotherapy makes the radiation much more effective locally. You'll receive radiation every weekday for about 6.5 weeks. The chemotherapy, cisplatin, is delivered 3 times, once every 3 weeks.
The side effects are significant. Adding chemotherapy increases the rate of severe side effects from about 34% to about 77%. You will develop a severe sore throat and mouth called mucositis. This typically peaks around week 5 or 6 of treatment. Most patients need strong pain medication and sometimes a feeding tube to ensure proper nutrition and hydration.
Beyond the radiation effects, the chemotherapy itself can cause side effects like nausea, potential kidney damage, and hearing changes. In terms of long-term function, most patients with a tumor this size recover good speech and swallowing, but it takes time. Our speech and swallowing therapists will work with you throughout. We have resources to help you with smoking cessation, as quitting tobacco is critical for treatment success and preventing a second cancer. Do you have any questions about this plan?
That script really highlights the risk versus benefit using the specific data from the R-TOG trial while being totally honest about that 77% severe toxicity rate.
Okay, let's discuss toxicity management in more detail. For acute toxicity, mucositis is universal, and with chemo, it's going to be severe.
Pain control, often with scheduled opioids and nutritional support frequently requiring a prophylactic or therapeutic G-tube, are just paramount to keeping the patient on schedule.
And we also have to rigorously manage the chemotherapy toxicities. High-dose cisplatin is nephrotoxic, so aggressive IV hydration and magnesium are mandatory.
Ototoxicity needs baseline audiograms and monitoring. And we have to watch for myelosuppression as well.
Moving to the late toxicities, which so often impact quality of life the most. What's number 1?
It's xerostomia, or chronic dry mouth. It results from damage to the remaining salivary glands. Management is lifelong artificial saliva and medications like pilocarpine, that's pilo-say-arpine, which stimulates any residual function.
And then there's the specter of osteoradionecrosis, ORN, of the mandible.
This is a devastating complication. Prevention starts before radiation, with mandatory pre-rad dental clearance extracting all non-restorable teeth in the high-dose field.
And post-treatment, patients need lifelong fluoride trays to reduce dental decay, which is a major trigger for ORN.
And finally, dysgeusia, the loss of taste.
This often gets dramatically worse during RT, leading to poor appetite. But partial recovery is typical, usually starting around 6 to 12 months after treatment, though it may never return to baseline.
And a final clinical pearl on acute management: we have to strongly discourage treatment breaks.
Because breaks prolong the overall treatment package time, which, as we discussed with the MD Anderson data, worsens outcomes due to that accelerated clonidine repopulation.
You have to manage toxicity aggressively to maintain the schedule, not stop the schedule because of toxicity.
Okay, let's finish with the high-yield board-relevant segment. We'll start with the classic oral board traps that examiners love to use.
Trap number 1. Adding chemotherapy for multiple nodes without E&E. For example, a patient has 5 positive nodes but no extranodal extension. They get post-operative radiation alone. The pooled analysis showed no established survival benefit from chemo in this group, so the high toxicity isn't justified.
Trap number 2. Starting radiation 8 weeks after surgery without acknowledging the delay. If you're presented with a delay, you must state that the package time is suboptimal and start treatment immediately, documenting the delay. You don't wait longer.
And trap number 3. Confusing a close margin with a positive margin. A positive margin is tumor on ink, a PE trigger. A close margin of less than 5 millimeters is an indication for dose intensity, maybe 60 gray, but it is not an independent chemo trigger.
Okay, now for our board pearls, the 8 high-yield takeaways every resident has to know.
Pearl 1. The big 2 for chemo-RT are positive margin tumor on ink and E&E.
Pearl 2. R-TOG 9501 showed LRC improvement from 72 to 82%. Justifying intensification.
Pearl 3. EORTC 22931 showed OS improvement from 40 to 53%, providing the survival mandate.
Pearl 4. Intermediate features like PNI and LVI trigger PORT, but not chemotherapy, per the pooled analysis.
Pearl 5. Acute grade 3 to 4 toxicity jumps sharply to 77% with chemo.
Pearl 6. Start PORT within 6 weeks of surgery to avoid worsened outcomes.
Pearl 7. Chemotherapy is for local regional intensification, not systemic coverage.
Pearl 8. A close margin reinforces dose intensity, while a positive margin triggers the chemo.
Time for the board blitz. 4 rapid-fire questions to test your application of these principles.
Question 1. A 62-year-old woman has surgery. Path shows PT, 2N, 2 disease, 4 positive nodes. Largest is 3.5 centimeters.
Right.
No E&E margins are negative. PNI is present. What's the most appropriate adjuvant therapy? A. Observation. B. Post-operative radiation alone. C. Post-operative radiation with concurrent cisplatin. D. Post-operative radiation with concurrent cetuximab.
The correct answer is B, post-operative radiation alone.
Rationale. She has multiple intermediate risk features, 4 nodes, large node PNI, but she lacks the big 2. The pooled analysis showed no established survival benefit from chemo, so we treat with radiation alone.
Question 2. A 55-year-old man is 6.5 weeks post-surgery. Path showed PT3N1 disease with one node containing ENE. He was delayed starting radiation due to wound healing. What is your recommendation? A. Begin chemoradiation immediately and document the suboptimal delay. B. Wait 2 more weeks. C. Omit chemo. D. Recommend observation.
The best answer is A. Begin chemoradiation immediately and document the delay.
Rationale. ENE is a big 2 indication. Even though he's delayed, further delay will only worsen the prognosis. You proceed with the highest intensity treatment right away.
Question 3. Which statement about the pooled analysis of the R-TOG and EORTC trials is most accurate? Chemo improved survival for all patients with multiple nodes. B. The clearest benefit was in patients with ENE and/or a positive margin. C. PNI was identified as a big 2 indication. D. Chemo primarily improved distant metastasis rates.
The best answer is B.
Rationale. The Bernier pooled analysis defined the modern standard, showing the survival benefit was concentrated only in the ENE and positive margin subgroups. Intermediate features weren't sufficient, and the benefit was local.
Question 4. Which patient is most appropriate for post-operative radiation alone? APT2N1 with 2 mm ENE, BPT4, AN0 with a positive margin. CPT3N2B with 5 positive nodes, no ENE, and a 3 mm margin. DPTT2N2A with 1 mm ENE.
The best answer is C.
Rationale. Patient C has multiple intermediate risk features, DACH-PT3, 5 nodes, close margin, but crucially lacks both big 2 indicators. Patients A, B, and D all have either ENE or a positive margin, which triggers chemoradiation.
So to recap the entire discussion for our resident audience, the big 2 indications for concurrent chemoradiation are a positive surgical margin tumor on ink and extranodal extension. That's the PE you pay the price for.
All the other adverse features, PNI, LVI, large nodes, multiple positive nodes without ENE, they all fall into that intermediate risk category. They trigger post-operative radiation alone, often intensified to 60 gray.
And cisplatin remains the standard concurrent agent at 100 milligrams per meter squared every 3 weeks. We use it for local intensification because the survival benefit is concentrated only in those highest risk patients.
And the final provocative thought to carry forward. If we agree that starting RT within 6 weeks is non-negotiable, what's the biological mechanism driving that urgency? It's accelerated collagen repopulation, the aggressive regrowth of microscopic cells once the primary tumor is gone. Delaying treatment is not an inconvenience. It is a biological opportunity for the cancer to defeat our planned dose, and we have to fight that clock every single day.
Now that we've mastered adjuvant therapy and the big 2 triggers, next time we'll shift to the essential practicalities of planning. Practical planning when the mandible is involved. We'll cover invasion patterns, surgical decisions, dose painting on the bone, and specific techniques for ORN prevention.
Complete practice oral boards at radonsmartlearn.com and subscribe to Radon Smart Review for our next installment. Thanks for tuning in.